Record.
Okay,
you guys. So I'm going to go ahead and get started with some of the housekeeping stuff. So for those of you that have not joined us on the office hours, I am Jennifer Haynes. I'm the membership chair of the Behavioral Health Nutrition DPG. I am going to be here mostly as moderator, kind of, turfing questions and stuff like that. And we have our lovely Jean and Matt here that are going to talk to, or kind of lead a conversation on how dietitians can be trauma-informed and how we can provide trauma-informed care. So we're going to do this a little different than how we've done it in the past. In the past, we've had kind of a little short presentation and then opened it up for questions and answers. And we would turn the recording off for the question and answer section so everybody would feel comfortable. But because this is going to be more of a kind of direct conversation, we're going to leave the recording on the entire time. But y'all are more than welcome, if you do not feel comfortable asking questions yourself or into the public, you can private message me a chat with any questions that you have, and we can get to them that way as well. So I just want to make sure everybody feels comfortable, that kind of thing. You don't have to expose yourself if you feel like you need to keep something private. Hopefully that all makes sense. Let me know if there's any problems with that. But that being said, I know that some of y'all are familiar with Miss Jean here. She is our IDD resource professional. So she's the one to go to when you have questions, and, she'll be lurking around in the discussion board, answering questions and stuff like that. And she did a awesome little interview with me when I first started as a membership chair to be the spotlight. So you can see a video of her on our website as well under the membership spotlights. And then we have Matt Bennett, who has been super helpful and gracious in helping us put this together. So Matt Bennett, he has a master's degree in community psychology and business administration. And Matt, correct me if I'm wrong, I feel like we have kind of two main focuses, and that first is a trauma-informed care, and then he does a lot of work with heart rate variability, which he may get to today, which is all super interesting and kind of ties in with our talk with Ms. Teresa last time. So Matt is super, super busy and super efficient in getting stuff out. So he has 5 books and 2 podcasts, if y'all are interested at all. I can, in a little bit when I get done running my mouth, I'll put in a link for him so you can get to his website and stuff if you want to learn more from him. But do you two want to go ahead and introduce yourselves and get started?
Sure. Thank you, Jennifer. I'm Jean Daniello. I'm honored to do this today, and we're going to talk with Matt about trauma-informed care. And really, I hope that it will be interesting to you. If you have questions, put them in the chat, and we will try to answer them. Just a little bit of background, if you're not familiar with me, I work at RICA Baltimore, which is a RCCI, and we have many children here who live here who have emotional dysregulation, and then we have day students who come. And I do not have a psychology degree. I'm a registered dietitian, but my experience here has I guess taught me a lot, and we try in the facility to use a trauma-informed care approach. So I'm going to open to Matt now. Matt, how are you today?
Good. Hi, everybody. Thanks for having me. Coming to you from Golden, Colorado today, where we got 8 inches of snow last night, and it is beautiful. So just if you wonder, my snowboard is waxed, and I hope to get a few runs in over the holiday week next week. So I'm excited to be with you all today. I always love it when I get a nutritionist, dietitianist in my trainings. It's sort of happening more and more, which I'm really excited about, because I really see the role that you all have is so crucial in this. I really believe that we have ignored nutrition way too long. And I hope to nerd out with you a little bit about how, from my mental health perspective, really, I need to learn how to talk, and a partnership is great because you have all the expertise in it, about nutrition, movement, the quality of sleep as part of trauma healing. I like to say, if I don't talk about those key aspects of resiliency, there's a real ceiling on how much I can help someone. So I see you and this group as just being incredibly valuable. a little bit about my practical experience as well. I think I've worked in facilities like Jean's most of my early career. I worked in child welfare early on in my career, a little stint in juvenile justice, learned that the justice system probably wasn't for me overall. I've worked in youth housing. I ran a school for special education where our students were too violent for the public school district. So it's a lot of similarities there. Before moving into public health, homelessness, I do a lot of work in schools nowadays, worked with police departments. And so I just try to spread the research, the word about this, hopefully continue the momentum of this paradigm, which has just been groundbreaking for me and my work with it as well. So I'm really excited to be here today, honored really. I just want to put out there, I've had some really good mentors with the health at every size. Sorry, I want to make sure I get the acronym right. Weight inclusive care. I will put out there, I'm really working on my language. I'm huge on person first language. I know there's words I might avoid, but I've been using them for decades. So if they slip out, please call me. I'll throw my email in there. I'm happy to be hopefully called out gently, but I'm working on it. So I am a work in progress, but I think it's really important. So I may say something I don't know is wrong. Please correct me. I want to give everybody full permission to do that, as I'm really dedicated to the learning curve I've been on, because I want to be in your world, but also to be respectful and really learn from you all, because the work being done with this, I think, is really crucial and fits really well into trauma-informed care.
Awesome. Thanks for sharing that, Matt. Your energy is just, you're so up. So do you mind maybe starting out with kind of like a definition of like what trauma-informed care, how it's different than maybe what we learn? I know you don't know exactly what we did in school, but like, where do we need to go, that kind of thing.
Absolutely. So really, if we want to break it down, it's the why behind the behavior. Even with a lot of student loan debt to get that master's degree in psychology, in the work that I did, I really didn't understand why did certain people seem to struggle. And I think the theme that I want to throw out here is really just disorganized, whether we're talking about eating, whether we're talking about relationships, whether self-perception is. Trauma really can create a lot of disorganization within the person. And so when I started to see, and I saw the adverse childhood experience study in 2002, and it just changed the course of my life because I was working in a facility like Jean's at the time. And if you ask me, why do certain young people struggle? Why do their families struggle?
Why do they struggle? Yeah.
Right. You could see this, and Jean, I'm sure you see it. There was a generational aspect to this. Why do folks struggle? And I didn't have they made bad choices, but it just didn't make sense of, well, why did we were disproportionate representation in our system. So when I saw the adverse childhood experience study, it gave me the answer of trauma. And it also gave me an answer of the neurobiological impact of that trauma. Is the youth, the families I was working with, their nervous systems operated differently. And go ahead, Jean.
Oh, yeah, I would just say that it seems to me to be generational. Like if you do a history, it goes back as far as they can report. Grandparents, uncles, aunts. There's a whole group of people who are not doing as well as they could, maybe.
Absolutely. We now have a science called epigenetics, where we sort of inherent, and I have to use binary. I haven't figured out how to do this without binary gender, so I apologize for this. But
don't worry, to me.
We get this epigenetic expression from our grandmothers and then from our fathers. And again, I'm sorry, I haven't figured out how to do grandmother non-binary at this point. I'm working on it. A sperm donor, you can replace us with sperm donor really easy. But so we really born to survive the trauma of our ancestors. But we know that can kick people into behavioral patterns as well. So we can actually see this, and there's a really great, if you're really going to be sort of the laypersons, it's asking what happened to this individual. And then collecting a team around it, which is why I love talking with you all of okay, what's this person need from us as a treatment team to help heal that trauma? Because the really great news of this is trauma heals in an amazing way. Like I always like to say, if you break your leg and you go to medical care and you get back to where you were before the injury, you're probably really happy with the medical care you got. The really cool thing about healing trauma is this idea of post-traumatic growth. In other words, if we get the support, the resources, the treatment that we need, and that's got to be multidimensional, what we know is trauma heals in a way, and I want to make this personal without making it too personal. If you've ever been through a hard time in your life, whether you label that trauma or not, and you're on the other side of that experience, I know I look back at the trauma in my childhood, and I can say, never want to go back there, but I'm stronger today for having gone through that experience. So we know the people that are still struggling, the people that end up in our homeless shelters, probably a lot of folks, Jean, that you work with, families and youth, people in our prison system, they're still in the pain and suffering side of that story. They haven't had that transformational experience. And that's where we all come together to hopefully allow the people to have that healing experience. And that's going to be your work. That's going to be trauma treatment. That's going to be creating a safe environment. So the social work aspect of this coming together, and what's this family system need to really heal?
I find there's also a real relationship with the children, the young people that I see, trauma and disordered eating, not knowing that it's okay to eat regularly, not understanding what their body needs. They have an inherent knowledge, but they don't act on it necessarily. So what have you seen between trauma and disordered eating?
Great. So that word disordered, I think that it could really be descriptive of so many of what I like to call the symptoms of trauma. My relationships are disordered, right? My relation with authority is disordered. My relation with drugs might get disordered as well. And so food in many ways, and again, I'm stepping into your expertise area here as with all the respect of what you bring to the table, it also it gets disordered. That food might, where instead of just providing substance for life, it becomes maybe a coping skill for me. It might become an addiction for me. Maybe controlling, with no food or extreme fasting is a way to gain control in a maybe unhealthy way for the individual to get some control over my life. So that's what trauma does. And again, we can see this reflected in the actual nervous system, how our nervous systems function. And food is going to be one of those potential things, as of unhealthy relationships, other substances, that I'm trying to gain some control over this disorganization that really is dominant in myself. And so if I can control something in some way, that is how I might use food to gain some control over my life. And then for so many people I work with, we've got food deserts, we have lack of access to healthy food. I think, they're just school lunches. I think I'm talking to huge advocates here for healthy school lunches. Hasn't always been the case, especially in communities that could really use healthy food in there. So yeah, absolutely. So you sometimes have lack of access to, lack of knowledge of, and then I'm using that in a disorganized way that can lead to a lot of unfortunate health outcomes in life.
Matt, what do you think, sorry to jump in, as far as the difference of using food to cope with trauma, either through like severe restriction or like the binge purge, that kind of thing, versus people that grew up who had food used as a source of abuse to them? Does that make sense? Is that a good question? Like, did I word it right?
Yeah, I mean, it's tricky, right? So, I mean, the thing with trauma-informed care that often gets overlooked is we're sitting across from an individual with a unique experience. So that is whether I'm talking about the use of drugs, whether I'm talking about the use of food, whether I'm talking about relationships, there's that unique history that can manifest in so many different ways. Even within the same family system, you might have people using, if you have 3 children, one that might be restricting, one that might be overeating, one that might be just fine, and that's not an issue for them. And so, it's really the question of understanding it from that. And I know I'm reinforcing what you do on a daily basis. What role does food play in this individual's life? And is it associated with their trauma? Because I think if we start to get somehow that association, probably then manifest in ways that become, and I'm stepping into your world here again, using my mental health model, but diagnosable issues that they might have there might meet the DSM diagnostic criteria. Is it's somehow related to either their trauma, like you said, being used as part of the trauma that they experience, or a coping skill that they may be using to cope with the pain and suffering.
Oh, I am so sorry. My phone keeps ringing. I'm going to give you a question and see if I have to answer it. No, it's my own daughter. But Matt, I know you talked earlier, but how do you see therapists working with dietitian nutritionists? And I'll just share this experience I have. This has been very difficult at this facility where I am. Granted, I'm the nutrition director, so I'm really running the food, making sure that our children here are fed and that they're growing and they're gaining weight. But the therapists in general are like, they have so much responsibility for the children. So they're very reluctant to share sometimes. They only really want me to get involved when things are really going south. Mm-hmm. The child is really losing weight, or doing some other things that, are unhelpful. But how would you recommend, like, a dietitian engage more with a trauma, with a health professional, mental health professional? It isn't easy in every facility, especially if you're not in the same department.
That great point. So a few things there is, I don't think my tribe, so to speak, in the mental health overall, if you look at the average mental health professional, understands your world outside disordered eating. And that's where I really hope that where we're evolving with trauma, for me, it's like understanding the role of nutrition and how it impacts the nervous system. Like, because that's our language now. We get nervous system. Now, we probably, unless you've gone and dug in your own within the mental health world, really haven't understood that or connected that with nutrition at this point. So I would encourage all of you to kind of do what I'm doing with you all. Like, I'm trying to step into your world, understanding that I don't have your expertise. I have interest in your expertise. I desperately want to get your expertise involved, and I know it already is in this conversation. But we need workshops at conferences. We need in services within the organization of disordered eating, yes. But I really think where we missed each other, and where I hope that trauma language can be the bridge to this is, I see nutrition as a big part of resiliency. In other words, the sympathetic ventral vagal balance. If we want to look at nervous system functioning, we know that what you put in your mouth is either going to exacerbate the negative impacts of stress with inflammatory markers, or actually mitigate the impact of stress. So Jean, with the facilities, we shared this story of, that I worked with, and I'm assuming I would recognize the youth in your school. what we call complex trauma, right? So some of the youth may have never had a moment of their life outside trauma, and they come in and we're trying to help them heal. And then I just have this nightmare, it haunts me to this day, of government issued corn dogs. And what we fed these youth should have been a crime. And I'm not corn dogs and French fries, and not even good corn dogs, and not not organic corn dogs, the worst corn dogs you could imagine. And French fries was the typical lunch. We were actually being productive.
We're going against what we need to do.
Yeah, absolutely. So
yes.
So it's being, I think the challenge is, how do you, yes, disordered eating, we need to have those we need you at the table to help us with that. But let's say somebody that is in your facilities or struggling in whatever ways with trauma, maybe it doesn't manifest itself as a diagnosable, disordered eating situation, but how can nutrition be part of their recovery? And there, to me, is where the gold is, because that's what we're looking for. Because if you tell me corn dogs and French fries are actually, activating the parts of the sympathetic nervous system and is counterproductive to my therapy, you're probably going to get my ears to perk up in a way to say, oh, this isn't just about the anorexia and everything else we've heard in school. This is actually for, me too, what I feed my family. And so, and for these other people that I'm working with that might, again, not have a diagnosable level with food, but, this can supplement what I'm trying to do to help this person heal.
Yeah. And obviously, framing that around what a person's willing to eat and what is available, and
Yes.
within the food security, and that kind of concept.
Yes, absolutely.
As well. I have a question here, Matt, that is really just asking you to expand on your brief mention on the vagus nerve and the polyvagal system, and in particular, how does that interact with eating disorders?
All right. Oh, okay.
He likes this topic, yeah.
Sorry, I gotta get my mid chest here. So there's a movement right now where trauma is really picking up. It's interesting to watch now, 20 years, and I came to the party probably about 7 or 8 years late to watch this paradigm evolve over time. As I like to say, when Oprah writes a book on your topic, all of a sudden the world knows about it a different way, which is really exciting. But one of the cutting edge pieces where I really think we have this great overlap is around something called polyvagal theory. And this, I'll give Stephen Porges his credit with this. And, this is it's on fire right now in the trauma-informed care world. And so, but it gives us a shared language that I think is really important here. So just really simply, I'm gonna do this a disservice for simplicity's sake. But the things that I really want to talk about, because you can go into detail, is one is we know we have the ventral vagal nerve, which is highly connected to our executive functioning centers, prefrontal cortex of our brain, but sits heavy on, located in our upper chest and heart. Also facial muscles, inner ear, but this kind of upper third sort of our body here. So ventral vagal nerve, highly correlated with executive functioning. Then we have our sympathetic nervous system, and I point to my mid-chest. I like to think, if you've ever seen an Iron Man movie with the Avengers, I think Iron Man gives us a great analogy for this. So Iron Man has this, I think it's called the apex conductor, and I'm not a big Marvel fan, but I've watched all the movies. So, what we know about the apex conductor is it keeps Iron Man alive. So he's not always in superhero mode. Keeps him alive. So our sympathetic isn't just fight or flight, but when Iron Man needs superhuman strength, it provides that energy as well. It's a great analogy for our sympathetic nervous system. People say it's bad because it's fight or flight, but honestly, if your sympathetic shuts off, you're dead. So we need it. So that's why I like Iron Man better than just fight or flight. And then we could, the dorsal vagal, which is associated with the freeze response, is in there as well. I think there's some controversy here, which I don't have any time to nerd out with you about. But if you have a free like 3 or 4 hours, I'd love to discuss where we're trying to work some of this stuff out. But the exciting thing when we think about where nutrition comes in here and disordered eating and trauma is usually what we see. And everybody is unique here. And I'll talk to maybe the exception to the rule here in a second. But what we see with trauma is there's more sympathetic activation. So what we'll see is resting heart rate is usually higher, and that ventral vagal activation is usually weaker. And so what we see with trauma is we get that higher levels of anxiety at baseline. And what I'm looking for when I have that higher fight or flight kind of energy, which is usually anxiety, but can also still be some depression as well. And I think these two go so hand in hand with folks with trauma, because being anxious all the time is also exhausting. So this anxiety and depression, even if it's not bipolar per se, really go hand in hand, I think, more than we kind of separate those artificially. So that increased sympathetic activation is what I often see from the mental health perspective of somebody walking in. So when we see this dysregulation, there's where we're all sort of pinpointing. Now, this is where those anti-inflammatory foods can play a big role, because one, I'm not exacerbating the negative consequences of the inflammatory response from that overactive sympathetic system. And so anti-inflammatory foods can be a real way to help mitigate the impact of trauma on the physical health of the body as well. So again, disorganized, it's what it does to the system, where my executive functioning part of my nervous system is just weaker. It's less developed, not because there's something wrong with the individual, but because of what's happened to them. And so we get this disorganization in our nervous system, which then is reflected in our behaviors. Again, maybe our relationship with other people, relationship with food, relationship with drugs. And I hope that's a somewhat synced answer to that question, because I can go on for 3 or 4 days, which I will avoid, but any follow-ups to that?
No, I think that's kind of a cool like nutritional tie-in, because a lot of the nutritional psychiatry research focuses on the connection or the communication with the gut bacteria in the brain through the vagus nerve.
Yes.
So we have a lot of overlap there in what I guess we do and what you're talking about. So
yeah, it's like I'd love to replace the corn dogs with kombucha and sauerkraut, right? The gut is so fast. Your world is so fascinating to me.
It's fascinating, yes.
Yeah. Fecal transplants, because there's a 13-year-old boy that lives inside of me, thought that was just hilarious initially. And then I'm looking at the research, I'm like, wait a minute, like,
it's life-saving.
Why aren't we, why is it, Jean, why aren't we doing this in the facilities like ours? Because we throw a lot of other pills down people's throat with a lot of side effects. So I think there's some really exciting, innovative space here.
I think we don't have enough yet, I guess, is where we are right now, right? We know that there's some stuff that can help. We don't have the pinpoint exact yet to be able to do something that drastic.
Right. It's really just in early stages, but
it's super cool.
and it has, people hear it, they're kind of grossed out, but I know they're using it for C. diff, difficile infections with success. For some people. But
in leaky gut syndrome, when we talk about trauma, because one of the advancements from when I first learned about trauma is we have now a lot of direct medical. Dr. Gabriel Mate has done just tremendous work on this. If you haven't read The Realm of Hungry Ghosts, it's a great book. He's just come out with a new one whose title is escaping me. So it's Gabriel Mate with a fancy thing. My Indiana accent won't let me say his name how I'm supposed to say it in French or whatever it is. It's Gabriel Mate, but yeah, my Indiana accent won't allow me to get there. So he's done a lot of great work. Is just what we know with the chemical release, the cortisol, the cytokines really erodes the gut and the immune system. So leaky gut syndrome, all lupus, other things that, again, are kind of out of my area of expertise, but we see so much impact on the gut due to a lot of that escalated level of cytokine release. So we've got a lot of folks, you know, again, Jean, you and I, who've worked in these similar facilities, I know a lot of you have horrible gut health, have horrific, and then we feed them corn dogs and French fries. And I'm like, you know, I just look back at that and say, well, you know, boy, let's think about nutrition as treatment, you know, and that's
exactly
trying
to get that message out when with teenagers, especially, who have grown up without vegetables or whole grains.
Right.
You know, just those two things alone, extremely difficult to get them eating them.
Yeah.
And you know, it's kind of frustrating because adults adult staff are also eating fast food.
Yep.
So, and they're bringing it in. So there's so much culture of still poor nutrition. I mean, the dietary guidelines say like 90% of Americans are not getting all the fruits and vegetables they should eat, which is necessary for a healthy gut.
Right.
And so we have a lot of work to do. And I'm also interested, you are also studying heart rate variability.
Yes.
And I found this really interesting topic, and maybe you can explain how that ties in with trauma-informed care and what heart rate variability is, because I don't think everybody knows about it.
Yeah, so heart rate variability, or HRV, is where my obsession is right now. I'll send you a link as well, if where you can download my latest book on the future of trauma-informed care, where I think this is going to take us. Because so heart rate variability, layperson's definition, the ability to handle or recover from stress. So if you think about my work with trauma, and I do work, obviously, trauma-informed care, but as part of that, we got to think about our own health and wellness, our own resiliency, the health and wellness of our organizations. So to me, there's like those pillars are just as important. So everything I've really studied, everything I've dedicated my life to for the last 20 years, the ability to handle or recover from stress. And here comes this biometric that has been around since the 60s, but now because of cell phone technology, we can take what we had to go to a lab and get hooked up to a $40,000 machine. Now for a $30, $40 device and a cheap app, we can start to measure this on a regular basis. So heart rate variability, if I can go back to the polyvagal theory, ventral vagal sympathetic interaction. So every time we inhale, we have this thing, let me go back for a second. We have this thing called the ventral vagal brake. And this thing is fascinating. So this is the interaction between the sympathetic and the ventral vagal. So every time I exhale, this ventral brake suppresses my heart rate. In other words, it pushes down on the sympathetic system and lowers my heart rate. And every time I inhale, I release that brake and my heart rate goes up. Exhale, down, inhale, it goes up. But this is called respiratory sinus arrhythmia. And this creates a variation in our heartbeat. So it sounds a little counterintuitive, but we want a higher heart rate variability. So if you think about it, a lower resting heart rate, there's just less beats per minute. So there is more room for variation within a minute, but you're really showing what you're measuring really is executive functioning, is overall health and wellness. Again, ability to handle or recover from stress. So now we have this biometric, and this is where I think our worlds overlap in a way that gives us a real powerful language moving forward. Is there is plenty of information out there about the connection between nutrition and heart rate variability. One of the things I'm fascinated with, just because it's free and it's had impact in my own life, is intermittent fasting. And I know fasting is a word we have to be careful with, and just all the asterisks is with folks with disordered eating may not be where we want to start with this. But if you just look at the research around this heart rate variability intermittent fasting, we see that 14 hours between last calorie and first calorie the next day really activates the ventral vagal and improves heart rate variability. So again, is that something that, if it's clinically okay for the individual I'm working with, something that we can think about looking at? So this is where, as nutrition trend, and I'm trying with my language here, so forgive me and correct me, as nutrition trends in a healthier way, we're going to see improvement in heart rate variability. As someone progresses through trauma treatment, we should see improvement in heart rate variability. As I work with somebody on healthy sleep habits and getting good restorative sleep, should see improvements on heart rate variability. Somebody integrates a trauma-informed mindfulness practice, should see increase in heart rate variability. So what my real hope is we have like one metric to rule them all that we're all working on. And if we can start to measure this, and in a way, Jean, that can be affordable for folks like us who are working with $1 million budgets for quality, really getting that data can show, okay, now Jean and her facility got a grant to have a salad bar. How is that impacting people's HRV? If we can start to measure these variables in different ways. So to me, to quantify things, to put measures on this, because I think, and I'm going to say something I may be stepping way out of my zone, is we've struggled in your world to find good, healthy measures. BMI falls way short. Weight falls way short. In fact, these are stigmatizing measures. And so I'm working with a disordered eating expert and this is just a work in progress. So don't take this that we got work to do on this, but is HRV the new BMI? In other words, it's a better measure of overall health and wellness without any of the stigma, because we're really measuring it. There are population norms, but what we want to see is improvement of the individual against their own baseline.
So maybe like a replacement for the BMI rather than like a new,
Yes, maybe that's, okay, I'm stealing it. Yeah, we're replacing that destigmatized measure. Again, we're trying to improve against the individual's own baseline. So it takes away a lot of that stigma that I know is associated with these other metrics.
Can I redirect to more of maybe something tangible is not the best word, but something actionable that as a dietitian, we have a client in front of us or a patient in front of us, like how do we put this trauma informed? How do we learn about it? Are there things that we maybe use that we shouldn't be in trauma? Like, how does that look different in our normal counseling, I guess is what I'm trying to say, to make sure that we are being, like you keep saying, I know I'm working on my language, like what language do we need to work on, I guess is a better way to say that. Yeah,
well, the health at any size, I believe that movement is really trauma informed, so from what, and again, I'm a newbie, which probably heard a few things slip out here and there, but, being a newbie in that arena, I really believe what that is, or weight inclusive, whatever label is going to eventually be put on this, really that not re-traumatizing somebody by saying how they're eating is wrong, or really the diet culture that we're in, or removing the O word from our vocabulary. All those things 100% supportive of. So I really think that gives what I know about the HAES approach, a really good framework that brings this together. The other thing is, really looking at understanding, again, the role, and I believe you already do this, so I'm probably supporting a lot. Well, what is the role of food within, their trauma experience? Taking away a certain habit or a certain food might be their coping skill, so if we take that away, what new coping skills can we build? There's a great movement in education about skill-based and realizing that, hey, if somebody's using what we see maybe as a coping skill that's disordered eating, what coping skills can we give them to replace that, and giving them time to really do that. So really understanding the role, how it's connected to trauma. And I probably don't have to tell you, this is where it's ideal, is you may be working with an individual from the eating perspective, working as a team with a mental health professional, working together as much as possible, or having referrals in your network. So, and I may just be talking out the side, but if you're doing more private practice work or you're not a part of a team, just making sure that you've got folks with trauma treatment expertise. So you hear things like EMDR thrown around, trauma-informed cognitive behavioral therapy. Making sure that you have those folks in your referral network are also key there as well.
Okay. Nancy has a question. Nancy, I can read this, or do you want to chat? Do you want to come off of mute?
I just wanted to ask if you could share on language that's more aligned with trauma-informed care when you're speaking with patients, or maybe certain language or words that maybe should be limited or avoided, and again, being aligned with trauma-informed care.
Yeah, great question. So the thing that I always challenge people to do is disconnect the person from the problem. So, we know that folks who've experienced, especially repeated, which we often label complex trauma, which often gets you to the post-traumatic stress disorder diagnostic sort of level, is that they've internalized these labels of who they are. So we know in the trauma world, we often talk about the personal narrative. And what trauma does is it really steals the positive sense of self. Also, that relationships are safe places, or the world's a safe place. So it steals that positive sense of self and often replaces it with the sense of unworthiness. So one of the things that we just really want to be cautious of is not reinforcing labels. So I don't use the word addict anymore. A person managing an addiction. If they're going to identify they're struggling with it, I'll let them identify that even. Instead of homeless person, a person experiencing homelessness. This is where, using the words, I'm going to use it and then step away from, like obese as a label, or diabetic as a label, is not productive. I do a lot of work in something called motivational interviewing, which helps the individual find the motivation for change. And we know that those labels are counterproductive to helping people reach their goals. So really trying to separate the person from the problem. This is where the Hayes model seems to be really doing this as well, from my experience with it and in my learning curve. So the person from the problem, trying to destigmatize the behavior. And again, not, and I'm using words I hope are okay, but like the fat shaming that goes on in traditional medical professionals. This is where we need your help, right? Because I look at somebody who I may look at them physically, how they present, and I'm like, oh, for health reasons, you need to do X, Y, and Z, without really understanding that how do I help them be healthy in the body that they want, right? And so this is where I think we got so much room to grow, mental health, but also just healthcare in general. So to eliminate the stigma as much as possible is going to be a key point to this. And this is where I wish I had a lot of this information earlier in my career. Not that I think I was doing terrible harm, but boy, I've just been doing so much tweaking to my language as I'm on my crash course in your world around this stuff, and unintentionally, using words that are no longer in my vocabulary, or I'm trying to pull out aggressively and not use, even though they slip from time to time.
Okay. Sue has a question too. I'll give you the same thing. I can read it, or if you want to jump on and ask, you can do that as well.
Yeah, thanks so much. Matt, what tests or labs or other markers should we consider, could RDs request that are associated with HRV that we can work with other disciplines to interpret?
That's a good question.
I told you they'd be good.
Yeah.
It's a good question as well.
So I'm going to give maybe a non-answer, but let me see. And Sue, please push back
Okay.
with follow-up to me. I want heart rate variability to be a new vital sign. That's where I think there's all the research since the 60s to show that this is the metric of your body's ability to handle or recover from stress, whether that stress is a COVID virus or a medical condition or psychological stress. Now, it doesn't tell you exactly what stress that is,
You're right.
but this is where, if I can look into the future, is for less than 50 cents a day, you could actually have somebody taking daily heart rate variability readings. And I know that doesn't translate into a clinic really well.
Well, actually, it currently does. I mean, a lot of our population do have EKGs or EEGs on a regular basis, depending on what clinical setting they're in. And so I'm curious as to whether, is there any, either baseline or anecdotal information or research that is looking at that type of material and then connecting it to individuals with trauma, because I mean, we do have historical perspectives on quite a few clients. I mean, in some settings, not all of us. I'm in the outpatient setting, but was in an outpatient PHP IOP where we did have access to regular EKG or EEG, histories and charts. And so I guess I'm just curious as to, are there clinicians outside of RDs that are actually looking at that to help support this? I mean, I'm just wondering what you say you want to use this as a new vital sign. Are you, where are you drawing that actual, clinical data from?
So I'm in the chat. I'm going to link you to my website, one of my websites. Yeah, it's just me.
Yeah.
So, and you can, it'll have that annoying pop-up. And you can download my heart rate variability book, which really dives into that in the detail that I would love to give verbally right now with this. But
I see.
Yeah,
I see.
so the short answer is, like, we've got these metrics, the time domains like RMSSD, SD, SNND, all these different metrics that we can use. So if you take the EKG and run, probably in most software now, you can get a heart rate variability reading, is really just looking at that. And if you're taking that reading every week, every 2 weeks, tracking that over time is going to give, again, I think a great measure of, how this person's managing the stress in their life, and so you could go into other domains and I give resources for that in the book that you can get in the appendixes as well, about what different heart rate variability measures are measuring, so to speak. But yeah, if you got somebody that you're getting EKGs on daily, weekly, even monthly, really, I see this as a great outcome measure, is looking for improvement over time. And then, if you have an Apple Watch on right now, that gives you heart rate variability right there. It's maybe not ideal if you really want to geek out about it, but it's good. And so a lot of people have it on their wrist already and can start to look at and get comfortable with these measures.
Yeah, thank you. Yeah, that helps. I'm curious as to how we move forward to interpret. Thanks so much.
Yeah, and Sue, please, as you struggle with that, if you look at the book and just even skim through it, reach out to me. Do not hesitate, because I can talk about this stuff all day long.
So Matt, I'm curious, and then Lenore has a question as well, but what in my head I'm seeing is, okay, I'm looking at glucose regulation. I have a number, A1C, that I look at and I can get it. Is there a measure, or is there a high and low that we're what if I look at a report and I can go, oh, their heart rate variability is not good enough, which is
right. So there are population norms. So absolutely, yes. The tricky thing about HRV, which it makes it, we like to say, so you got population norms, but we know genetic variation. There's a lot of genetic variation in between people in the same demographics. So what we say is, look at it, be interested, be curious about it. So how does their HRV compare to their population norms? And then what we really want to do is to improve it over time, depending on whatever those initial baseline readings are. So it's really more of a metric to base improvement off of. So as eating habits improve, maybe they're getting a little movement in, a little mindfulness, maybe trauma treatment, we should see heart rate variability increasing over time. So there are standard measures out there that you can refer people to. I am so huge on the stigma piece that I really struggle. Like, I want you to look at it, and then I kind of want you to forget about it. And how do we improve off your own?
So compare the patient to themselves, basically.
But there's definitely, and then you have a group like, say, in Jean's organization, I know we burn out so quickly, Jean, in these. So
we turn over. It's a huge turnover.
You've got your team, and let's say staff are taking heart rate variability measures. You got 10 staff. Then you've got a big enough in where that average of those 10 people can start to tell you something in a very different way.
Okay.
I have a question, Matt. Are you aware, are there any cardiologists working in this area and really looking at this? Because like I see a cardiologist, they have never talked to me about heart rate variability.
And actually,
but they will tell me to get my stress under control.
Yep.
Real quick before you answer, just because we're running low on time, that ties into Lenore's question too. She's asking about the effect of beta blockers.
All staff members who are available.
Yes, that's a great question.
Yeah, so beta blockers, they should. So this is a little tricky. So beta blockers should improve heart rate variability if they're helping the condition that they're treating. So I don't feel like I have probably enough expertise on that specifically to answer with a ton of confidence.
Okay.
So
question was for those that are taking them for anxiety.
Yes, should improve heart rate variability, because what you're doing is you're regulating the sympathetic response. That's what you're regulating the amygdala, which is connected superhighway to the sympathetic. That's what we're measuring in many ways, is the activation of the amygdala or the anxiety areas of the brains. So should see improvement with an effective treatment, whether that's changes in habits or whether that's medication, should see healthier habits. Jean, answer to your question, we had this funny experience about a couple years ago, is that we were talking to cardiologists, me and my partner in this effort, and never heard of heart rate variability. It's like, well, I'm a cardiologist, I haven't heard about this. Then went home and Googled it and said, oh, you all are on to something. So I titled, the subtitle of my book is The Future of Trauma-Informed Care, because this is where we're going. One of the things I see sort of with the future, and you'll see my dog's tail as a shark in the background there. So Moose is ready for a walk, you can tell. But one of the things that's really exciting about this is still so many people haven't even heard of this term yet, because it's been in the laboratory. Just in the last about 5 years, we've now found a $20 device, right? So now all of a sudden, and for the populations I work with, I want it to be affordable because they can't afford a $400 smartphone. So looking at now, we've got hundreds of thousands, well, probably about 100,000 peer-reviewed journal or research articles out there. We got Polyvagal, Stephen Porges's work, Vanderkolk's work, all these different people who this has always been known to be the metric to measure the stress response. Now we can do it in a practical way. Jean, in a facility like yours, who just a $40,000, $50,000 EKG machine, just not practical. A tech to run it, not practical. Now it's really affordable. So that's the exciting thing, that a $10,000 grant gets everybody on it for a couple of years. So that's the exciting piece of this.
It's very, very exciting. Yes, it's fascinating work that you've been doing and sharing with us today. I guess we have just about, and we are at the end.
That's what I was gonna say. I want to be respectful of everybody's time. I don't know how much overflow y'all have available, or if there's any other questions even, but.
Yeah, and as those may come in, just interrupt me, but I want to thank you for your work. Thanks for being on this call. Learning more about the group that you're in here, just seems to be some really amazing work that you all do. So thank you for doing that. It's populations. I know a lot of you work with populations that are what I've dedicated my professional life to over the years. So I want to thank you for that work. Please find those venues, in-service trainings, come crash our conferences. I think mental health and nutrition probably gets you a workshop. Trauma-informed nutrition probably gets you a workshop.
Yeah,
So
we may have
please
to keep in contact with you, Matt, for sure.
Yeah.
And for everybody else, just real quick, I did drop my email in there. If y'all have any feedback or questions or anything, I can forward it to Matt as well.
Yeah.
And then honestly, just so y'all know, this kind of topic came about because somebody shot me an email asking for it. So if y'all have any other, just, requests for discussion for office hours and stuff like that. But Matt, we super appreciate you coming to talk to us about that. And I don't see any other questions coming in. So you guys, I know I say this every time, but eventually we will get these recordings up. We're trying to figure out if the website or creating a YouTube channel is going to be the best, but it will get out there and I will throw it probably on the discussion board is the best way. Thank you, Jean, for doing this at work, by the way. But I'll put that up there as soon as I have a good spot for it. And again, just thank you guys for joining us, and be sure to give me feedback because I really want this to be something that is helpful and beneficial to you guys. So
thanks, everybody.
All right. Thank you, Matt. Thank you, Jean.
Thank you, Jennifer. Thank you, Matt. I will stay in touch. This was so interesting.
Please do. Please
Thanks
do.
so much.
Take care.
Yeah. Thank you.
Bye.
All right. Bye.